Hello, I'm Dr. Celia Manby. I'm a medical oncologist in Atlanta, Georgia, and I'm coming to you today to talk about the impact of COVID-19 on breast cancer care. March 11th was the day that the World Health Organization declared COVID-19 as a pandemic, which basically meant that there was an infectious disease that had spread across the continent or perhaps even worldwide. On the same day, the United States declared COVID-19 is a national emergency. We learned the term social distancing, and our life changed. Everyone's life changed one way or another. We were scared to travel. We were scared to come in contact with people, and some of the necessities in life became unavailable or very, very expensive. And there was a lot of delay in many healthcare issues, but in particular, what we wanted to talk about today was the delays and the impact on breast cancer care. And first, I really wanted to discuss sort of why that was. The Center for Disease Control, the Center for Medicare and Medicaid Services, state, local governments recommended that healthcare systems delay elective care. They included certain facets of surgery, screening evaluations, urgent, non-urgent, non-emergent treatments were considered elective and were not allowed. And truly, these things were held because the attempt was to protect the public from being exposed to COVID-19, but also, and maybe even more importantly, it was to help save resources for patients if they were to become very sick from this illness, namely having hospital beds available, having personal protective equipment, or what they're calling PPE, which means getting masks and sanitizer, gloves. Blood supplies at the Red Cross were at an all-time low, and also have medical staff time services available for patients in most need due to the illness of the virus. With breast cancer, there were some unique risks for patients with breast cancer. Now, most of us have read and heard about COVID-19, maybe experienced it, but most people infected with COVID-19 will have mild to moderate respiratory symptoms, and most will recover without requiring any special treatment or hospitalization. According to the CDC, having cancer currently increases your risk of having serious complications if you do become infected with COVID-19. It's not known at this point whether or not having a history of cancer increases your risk of serious complications. Why is there a higher risk for patients with breast cancer? In general, any cancer diagnosis puts stress on a person's body. Just having cancer is an increased state of stress, which makes a person more vulnerable. Some treatments that we give, in particular things like chemotherapy, can cause patients to become more immunocompromised, which makes them more vulnerable and susceptible to viral infections. Some of the treatments that we give can increase a person's risk for lung disorders. And because COVID-19 is largely a respiratory illness, having fragile lungs or impacted lungs can have an impact on this most vulnerable part of the patient's system. When patients go through chemotherapy for a limited time for breast cancer, typically patients' immune systems recover within a couple months of finishing chemotherapy. That is determined by a lot of issues, but in general, it's a couple of months. Sometimes if people have comorbid illnesses or certain medications that can make their immunocompromised state be harder or more difficult to recover. It's unclear, as I said previously, if prior systemic therapy puts patients at a higher risk for getting COVID-19 or the serious complications from COVID-19. And we do know, however, that patients with ongoing therapy, particularly patients with metastatic breast cancer, usually have a weakened immune system. Patients in particular with metastatic breast cancer that involve the lungs can have progressive lung problems if they develop COVID-19. Some chemotherapy and targeted therapies can cause lung problems in themselves. It can put patients at higher risk for serious COVID-19 related complications. Patients with breast cancer are at a greater risk for developing serious complications from COVID-19 if they are over 65 years of age, if they have chronic obstructive pulmonary disease or COPD like emphysema or chronic asthma, if they have serious heart conditions, if they have type 2 diabetes, CKD or chronic kidney disease, sickle cell disease, if they're overweight, obese, and if they smoke. And we also know that if you have any combination of these comorbidities, that can increase your risk exponentially. So shortly after the pandemic was declared, COVID-19 and Cancer Consortium, that what we call the CCC-19, was formed. It was kind of a grassroots organization that basically was looking at the course of illness among patients with COVID-19 and a current or past diagnosis of cancer. It started, as I said, actually on social media and extended to involve, at this point, over 100 cancer centers worldwide, as well as some individual practitioners, all of whom are supplying data for this organization. So there was a cohort study that was published in the Lancet May 28th, and it included information on 928 patients who were diagnosed with cancer in the United States, Canada, and Spain, who also were diagnosed with a confirmed diagnosis of COVID-19. And a cohort study is it's a longitudinal study where you're looking at a group of people with a similar problem, let's say. So in this cohort study, they were looking at patients who had either had cancer or actively treated for cancer and who had been diagnosed with COVID-19. Again, it was 928 patients. The median age was 66. 30% of the patients were over 75 years of age. Now, again, this was a study that looked at all cancer types, but interestingly, 21% of the patients had breast cancer, and 16% had prostate cancer. 39% of the patients who were studied in this research trial were on active chemotherapy treatment, and 43% of the patients had measurable or active cancer. 13% of the patients in this study, so 13% of the 928 patients died. This is approximately, at the time, was twice the death rate for all patients with COVID-19. The higher risk of dying for patients with both cancer and COVID-19 was linked to the same risk factors for patients without cancer who got COVID-19, namely being older in age, having comorbid illness, so corresponding illnesses such as diabetes, heart disease, kidney disease, and being male increased the risk of serious problems. Again, so what this study really showed us was having active, what we call measurable or growing cancer, increase the person's risk of dying, and having a poor performance status. Performance status is a measure that we use in oncology to determine how active a person is who is diagnosed with cancer, if they're able to do their activities. So somebody with a poor performance status might be more bedridden or limited activity. So patients that were more limited and had active cancer were more vulnerable to the side effects of COVID-19 and death from COVID-19. The cancer type and the cancer treatment themselves did not appear to affect the risk of dying from COVID-19. So it didn't seem that having a certain type of cancer made somebody more vulnerable. Underlying medical conditions seem to increase the risk of COVID-19 complications more than the breast cancer treatments did with regard to breast cancer. We still need to do more research, and we all know that research is going on routinely. But with regard to breast cancer, we need more research to really understand how cancer diagnosis affects the outcomes of COVID-19. So I wanted to also spend some time talking about COVID-19 and healthcare and what we're doing in terms of safety strategies. In our clinic, in most clinics, we screen for COVID-19 symptoms. Even the night before a patient comes into the office, we are calling to see if they have any fever, chills, respiratory symptoms, if they've been exposed to somebody with known diagnosis of COVID-19. We wear masks, everyone, and we provide masks to the patients. And we also wear shields. We've adopted, like most medical practitioners, telemedicine services. We have physical distancing, meaning that the room in the waiting room, the chairs are separated by at least 6 feet. We know for patients undergoing any procedure, and in particular surgeries, they get COVID-19 tests before. Hospital stays are being limited, and we're also limiting visitors. In our clinic, we know that can be pretty tough on our patients going through chemo and getting sometimes tough news to hear and take on their own. One of the things I thought was interesting is that they've done multiple online surveys of patients with breast cancer and have asked them what their perception is of their care as they've gone through the pandemic. The biggest one was probably from the American Cancer Society, but online surveys suggest that 32% of the patients felt that their clinic visits have been delayed as a result of the pandemic. Surveillance imaging for different CAT scans, et cetera, have been delayed by 14%. There was a perceived 11% delay in mammograms, which I really found surprisingly low because I've had multiple patients tell me that they've had difficulty getting their routine screening mammograms scheduled on a regular basis. And surgery, anywhere from 10 to 30%. And the wide range there has to do with the fact that mastectomies, lumpectomies have been being performed on a fairly timely basis, especially lately, but sometimes we've seen delays in reconstructive surgeries, which are felt to be quote-unquote more elective. So that's why there's a range in the surgery category. Interestingly, chemotherapy and radiation therapy have been very timely, very little delay, about 5%, if that. Interestingly also, 30% of the participants in the survey stated that they themselves chose to delay or change treatments plans due to their concerns about contracting COVID-19. 80% of patients reported anxiety about their care being affected by the pandemic. 58% of the participants have used telemedicine services. 26% of patients reported that either they or a family member had lost their job as a result of the pandemic. 42% reported that they or a family member had had their work hours reduced as a result of the pandemic. And as a result, people are quite worried about their insurance, among other things. So with regard to COVID-19 and breast cancer care, as I said before, most mastectomies and lumpectomies are currently being scheduled in a very timely fashion. However, at the beginning of the pandemic, there were significant delays in these surgeries because as extremely important as they are, there was a feeling that they could be considered elective. And as I said, also reconstructive options have been postponed or changed to different surgeries, some with more reduced recovery time, shorter surgery time, that might make less need for blood transfusions, etc. From a medical oncology standpoint, we've been doing more neoadjuvant therapy. Now, neoadjuvant therapy is when we give therapy before surgery. So typically we're referring to systemic chemotherapy before surgery, but now with the pandemic, we've been giving a lot more hormonal therapy before surgery because there is sometimes many weeks delay of getting surgery, and these are basically medicines that the patient would require anyway, but the point is that we would be starting the medicines before the actual surgery, whereas in a different time we would have done it after the surgery. The goal of any neoadjuvant therapy is to it's preoperative therapy, and the point is to slow or stop the growth of cancer or shrink tumors. And we do that quite routinely in general. But because of the pandemic, we were probably doing it more frequently when we knew the patient was going to need chemotherapy after surgery. In terms of systemic therapy, again, we're talking about chemotherapy, hormonal therapy, targeted therapies, immunotherapy even, most patients were able to start or continue their systemic chemotherapy without any delays. Many people may have heard the term growth factors. Growth factors are medications that we give to help stimulate the bone marrow to make more white cells to help stay ahead of infection. And we, as a group of medical oncologists across the country, were advised to make those medicines more available to patients and to anticipate giving it to stay ahead of those vulnerable periods when patients' white counts were low. This would help keep the patients safe, reduce their risk of getting infection because their white cells are one of the main lines of defense. Most patients were able to start radiation without delays once surgery was completed. Shortened durations of radiation regimens were considered when appropriate, and I think that's fairly true regardless of the pandemic. If there's a shorter course of radiation that's appropriate, that's typically offered. But I will say that systemic chemotherapy and radiation therapy were impacted by having surgeries delayed, and in particular radiation therapy. Clinical trials. Now, clinical trials are research trials that patients participate in, and in the setting of breast cancer, it might be a trial looking at a new medicine to see whether or not it helps slow the growth or it's as a treatment of breast cancer. But in general, fewer people have enrolled in clinical trials for breast cancer treatment starting in March. Medical centers have limited new enrollment to prevent possible exposure to COVID-19 and also to preserve PPEs and other resources. Also, there's a big shift in clinical trials to focus on COVID-19 treatments. Some people also, again, chose not to join clinical trials because of the pandemic and the perception, the reality that they would have to be seen more frequently, etc. Breast cancer screening, March through June of this year, many radiology and imaging centers stopped doing routine mammograms for people with no symptoms. Imaging tests were still being done in a timely fashion for patients with high-risk lesions. For example, if a patient felt a lump, if a patient had a breast abscess or any bloody nipple discharge, patients with a finding, or what we would call a diagnostic mammogram, they were done very promptly. But for screening type mammograms, those were held for a lot of patients. There was another group formed in March. This is a multidisciplinary group. It was called the Pandemic Breast Cancer Consortium. This was a different consortium, but this consortium was looking particularly at breast cancer and COVID-19, and basically was there as a platform to give us guidelines for patients' care during the pandemic, access to care, recommendations, how to prioritize breast cancer care and different facets of patients' care. And the representation was from medical oncologists, surgical oncologists, radiation therapists, the groups that do our guidelines for therapies. Multiple experts in the field are involved in this consortium. So what can we do? From our standpoint, you have to schedule your mammogram. I think now is a good time to schedule your screening mammogram if you haven't gotten it done, if it got delayed or postponed. It's always important to ask questions about your care. One in particular is my care being altered in any way due to the pandemic? And is that going to affect my outcome? And also get a second opinion if you feel like your care has been in jeopardy. We have to do our part. You have to do your part. Hand washing, wearing masks, no matter what, is key and vital to keeping this under control. You have to watch for, there's a new term called caution fatigue, which is when we get so overwhelmed by wearing masks and shields and gloves and sanitizers that we think, it's okay, we're all right. That's called caution fatigue, and that is a big problem. Take advantage of telemedicine services. Those are the services where you can call. There's no reason that you have a specific time and appointment, and there's no reason to miss appointments with your medical oncologist, with your primary care physicians. these services are there, and even surgery follow-ups are sometimes done by Zoom-type meetings. And interestingly, a lot of people's insurance do not charge copays when you do telemedicine services, so it might end up being cheaper, which is not a bad thing. Avoid high-risk situations like crowds. Obviously, we're all missing important family events, and it's a tough time, but those are situations where COVID-19 has been very prevalent if you're in a group of people. Don't avoid treatments, though, because you're afraid of contracting the virus at a clinic or hospital. That's a big mistake. There are multiple protection, layers of protection in place in these settings. And I would ask, on behalf of all my colleagues, to understand the challenges that the medical team might be facing as well, and realize that any of the guidelines we're telling you and the restrictions we have in our offices is to keep everyone safe. It's really important to take care of your mental health always, and in particular lately, there's a lot going on in the world. And you have to stay vigilant about your safety. Remember, there's a difference between feeling safe and being safe. And remember, COVID-19 doesn't stop breast cancer. Early detection saves lives. Thank you all for your attention, and I am available for any questions.